Good afternoon. I'm Carolee Lee, founder and CEO of WHAM, Women's Health Access Matters. And on behalf of WHAM and our partners, the La Jolla Institute for Immunology and Northwell Health's Katz Institute for Women's Health, thank you for joining us today for what promises to be a fascinating discussion with the foremost leaders in autoimmune disease. June 2023 will mark the 30th anniversary of the NIH Revitalization Act of 1993, which established guidelines for the inclusion of women and minorities in all NIH-funded clinical trials and research. And at that time, it took a committed group of bipartisan legislators who collaborated with many different constituents, including patients, providers, advocates, and policymakers, to develop and approve this momentous event. But we still have a long way to go. WHAM is determined to build a new dialogue and platform to shift these imbalances, which still exist, even though some progress has been made. Accelerating women's health research and investment is an economic imperative that offers tremendous returns for small investments. And joining me today are exceptional leaders in their fields. Dr. Lisa Christopher Stein, Professor of Medicine and Neurology at Johns Hopkins University School of Medicine, and Director of Johns Hopkins Myositis Precision Medicine Center of Excellence. Megan O'Rourke, author of New York Times bestseller, The Invisible Kingdom, Imagining a Chronic Illness, who we hope will join us. She's had a bit of a delay. Dr. Erica Ullman-Sapphire, Professor and President and CEO of La Jolla Institute for Immunology, and Dr. Sonia Sharma, Associate Professor at the La Jolla Institute for Immunology. I am so grateful that all of you could join me today. And the dialogue will be followed by a Q&A. So please post your questions in the Q&A section below and we'll do our best to answer them. We'll begin with a brief history of women's health over the past 30 years, the status of where we are today, and where we need to be in the next 3 years, not 30. So let me start by introducing Dr. Erica Ullman-Sapphire, who's the first female president and CEO at La Jolla Institute for Immunology, as well as an active laboratory professor known internationally for her efforts in fighting such deadly viruses as COVID-19 and Ebola. She's also an essential part of our WHAM collaborative and has become a dear friend. Erica, I know that we'll hear later from Megan how frustrating it can be as a patient to get answers, and from Dr. Christopher Stein, how frustrating it is when physicians can't provide answers. But tell us and share with us, where does research factor into the equation? And where do you see the role of an immunology-focused institute like LJI to ease the pain of both patients and physicians?
So research has an absolutely central role. So when doctors don't have anything to offer or can't quite figure out exactly what's wrong with you, it's because there isn't a clear diagnostic. And if there's not a clear diagnostic, it's because there's not any information yet about a thing you could measure that to determine exactly what the source of your illness would be. And this is a primary problem with autoimmunity in particular. And actually, it was reading Megan O'Rourke's book that really hit home what this is like from the patient standpoint, that if autoimmunity tends to be, organ diverse, it might be involved in of skin and joints and general fatigue and pain. Fatigue and pain can come from a lot of different sources. And unless there's some kind of test that says, your levels of whatever are 100 and they ought to be 3, it's difficult for a doctor to actually figure out what it is because that information just isn't there. And without some precise information to say, you have such and such syndrome and you need this treatment, they just say, well, you have fatigue and pain. And it's kind of tempting for them to say it's kind of all in your head. And the reason they might say that are the things like fatigue and pain. And if there's nothing visible and nothing measurable, it's very qualitative and it's very subject to someone's experience. And the unfortunate thing is that autoimmunity predominantly affects females. And there's some sociological interpretation that, female pain might be more discounted. And so the role of research is to put something measurable, something quantifiable, a molecular reason, We know that you feel poorly, and you feel poorly because we have measured an enhanced inflammatory signal, which has arisen because you have 3 times the amount of factor XYZ as you should have, and that came because of this. And so what you need to control that and feel better and return to work and caring for your family is this therapy right here, or this therapeutic vaccine. So the role of research is critical. The role of research is to put a quantifiable, a reason, a diagnosis in place. The role of research is to understand the mechanism of what has gone wrong and to put that treatment in place to set the patient back right again. And it's critical that we do this research so that information is there and can be used by doctors.
Well, first of all, we're incredibly grateful to you and to LJI for the research that you're doing. And it's been a little bit over a year, which I recall very vividly since you became president of the La Jolla Institute for Immunology. Share with us, if you can, a little bit your long-term vision now that you've had a whole year under your belt. And I know that's probably, I shouldn't even say long-term. How about just midterm vision?
Exactly. So this is an extraordinary place. So if you're not familiar with what a nonprofit private research institute is, what it is, in a single building, we have 25 of the world's best immunologists, and we all have different tools in our laboratories, and we all come from some different focus or some different aspect. But every part of the immune system works together. And you know from COVID that you need B cells, and you need T cells, and you need innate immune responses. By these faculty working together, we can figure out how the immune system works and how the different parts influence and strengthen each other and create activity. When I joined this institute, I saw that we had these extraordinary minds and just absolutely fantastic tools, the best facilities I've ever seen. And we began the process of figuring out how to align the forces, to not just do, I'm doing this project, well, I'm doing this project, but to figure out where the force vectors align so that we can create better and bigger progress for human health in a certain direction. So we did a year of collaborative strategy, beginning in small groups. What are the problems that you really want to solve? What's preventing you from solving them? And something that was underlying the research dreams of nearly every single professor here was an untapped source of information, that we all study human cells, and all of those human cells are either XX or XY. Not just reproductive cells, all your immune cells, your T cells are XX or XY. And whether they're XX or XY, meaning what chromosomes are encoded and what genes are presented and under what hormonal control these genes are turned on and off, strongly dictates different biochemical pathways. So it's a source of information. If we have activity A and activity B, and activity A leads to disease, that's a source of information that you can go and follow. We might find, so, and you really want to hear from our Associate Professor, Sonia Sharman, some of the things she is finding. So, if you look at one pathway and you find a marker of disease, that gives you an opportunity to figure out what the therapeutic ought to be that could treat both sexes. So the vision was to mine this untapped source of information. People didn't think about sexual dimorphism in the immune response as much as we should have before. But the more we look at it, the more we're mining, the more information we're having, and the more information we can use to address all kinds of diseases, autoimmune diseases, neurodegenerative diseases, heart disease, infectious disease. Nearly every human disease involves the immune system in one way or another.
Well, I'm so excited for the work that you're doing, and obviously I'm also humbled and honored to be part of it. And I'm just thrilled that WHAM has been able to partner with LJI in fact, studying this broad initiative that focuses on sex-based differences in the immune system. So what are your hopes and dreams for this new initiative? And how will you know actually if we succeeded, since 80% of the people who are affected by who are affected with autoimmune are women? So obviously, we're very hopeful for you to find lots of good observations and results to improve our lives.
Well, what I'm hoping is that research can put into doctors' hands what they're currently missing. So autoimmune disease can take years to find and diagnose because there isn't a clear test, because we haven't understood all of the clear mechanisms that we need to. It's difficult to treat without just a blunt suppression of the immune response, which might leave that patient vulnerable to infectious disease. We need precision treatments. So my goal for this research is to find the causes of disease, find the opportunities for treating disease, find opportunities for much more personalized medicine, not one size fits all, but at a very minimum, two versions, men and women. The market has figured out that we don't sell the same kind of blue jeans to both sexes. Surely, when it comes to life-saving treatments, we might modulate those to fit people better as well. And you ask, how do we know when we've succeeded? Well, the thing about research is that it's very much a moving target, and we're always getting better. So a good analogy might be, we've invented a wheel. Fantastic. Now we can put a cart on a horse and we can move goods, but it's still really slow. So we needed to invent internal combustion. Fantastic. Now we have cars and trucks and we can move faster, but we're still limited to the ground. So we invent airplanes and now we can really move somewhere. But we're still limited by something else. So it's going to be a constantly evolving strategy. And we're going to know we've succeeded by all the different milestones along the way. We've figured out a mechanism for this disease. We've put a diagnostic in place for that disease. Each one of these steps and new sources of information are going to push us toward where we ultimately want to be.
Well, I'm delighted to be able to partner with you and support LJI. And thank you so much for sharing the importance of the research that LJI is doing in sex-based differences. We'll come back to this, we'll continue with Sonia, who I know is very focused on this. And let me turn to her because her research, in fact, is all about sex-based differences. So Sonia is an associate professor at LJI, and in her laboratory, she's looking at sex-based differences in neurodegeneration and why Alzheimer's and Parkinson's affects men and women differently. Sonia, I'm fascinated by your research, and I wonder if you can give us a quick preview of where the research is in this area and where is it going to be going in the future. Let's just start there. Where are you now? Where are you heading?
Absolutely, Carolee. What a great question. Where is the research right now? In its infancy, and in some ways that can be daunting, but in other ways, it's really a new frontier. We're really at the beginning of appreciating that there are, accepting in some ways, and then appreciating that there are bona fide differences in the immune system when you compare men and women, and therefore in immune diseases. And Erica mentioned that almost any disease is an immune disease because the immune system just impacts every organ system in our body. And so my lab is studying autoimmune or autoinflammatory diseases, neurological diseases like Alzheimer's disease. And Alzheimer's disease is a typical example of a disease that is very different in men and women at multiple levels. But maybe the simplest is just that women are about twice as likely to develop Alzheimer's disease during their lifetime. And this is even when we adjust for the fact that women typically live longer. And when we drill down into the pathology of the disease that men and women experience with respect to AD, it's a different disease. Women have more pronounced brain pathology, more pronounced inflammation, for example. Now we know that. So where are we? We don't know why. We really don't know why. We know that to some extent, sex hormones play a role in this, estrogen and testosterone, because in general, we've known for many years that estrogen is immunostimulatory, whereas testosterone is immune suppressive. So therefore, we would say that women who have more estrogen have a more stimulated immune system. That's about it. I mean, we also know that estrogen and testosterone regulate certain important genes in the immune system. So we have clues there, but really the definitive mechanisms, I think it's, as I said, it's a good time. There's a lot we don't know, but there's a lot to be discovered.
And so what will you need to make this research successful?
That's a great question. As Erica mentioned, research has to occur. We want the research to go rapidly, but there are many factors that can not hinder, but cause it to go slower. And we're always aiming to promote the research to go quicker. I would say that, our funding bodies are, which most of us researchers at LJI rely on the National Institutes of Health or other funding bodies to fund the important research that drives this discovery. However, these methods are often slow. It takes time to vet these grant applications. I would say what will make this go faster is you guys, it's education, it's advocacy, it's involvement of the public in these, in what we're doing, in what we should do, communication, because, that all fosters, it fosters philanthropy, for example, that can really allow us to go quickly. And in some ways, I would just like to say that philanthropic dollars in research, in some ways, they go so much farther because they come at the right time and can elicit rapid discovery.
I'm sure. Talk a little bit about COVID-19, because the pandemic is approaching the end of its third year, and COVID emergency measures have been lifted mostly around the world, but millions of people we know are still suffering from long COVID. What do we know about that? Because I know you're also involved in that research.
Absolutely. And remember what I said about in general, women who have estrogen or individuals with estrogen will have a more stimulated immune system, whereas in comparison, men who have higher levels of testosterone will have a more suppressed immune system. So in terms of long COVID, what we think is that women are actually more prone to long COVID because long COVID appears to look more like an autoimmune or an autoinflammatory disease. And that's what we're seeing. To take that into brain research, there are emerging studies showing or suggesting that the neurocognitive complications of long COVID may actually involve neuroinflammation in similar ways as some of the neurodegenerative or neuroinflammatory diseases like Alzheimer's. So there may be overlap there.
So a male child born in the US today will live to be about 74 and a half years old on average, while a female child can live to be about 80. And within the European Union, these are 77.8 and 83.3 years, respectively. You've already told us that there are significant differences in how the immune system works in men and women. And so do these sex-based differences play a role during the aging process as well?
They absolutely do, Carolee. They absolutely do. Research in my own lab on Alzheimer's disease, what we are doing is we are profiling the blood of women and men who don't have Alzheimer's and to compare it with those who do have Alzheimer's. And what we found by looking at Alzheimer's in this way is that there are molecules, there are protective molecules that we actually detect in the blood of women who don't have Alzheimer's that are missing in women who do have Alzheimer's and that are also missing in men who have Alzheimer's. So these uniquely protective molecules in the blood of younger women, and that's the kicker there with age, is that we're seeing this protective molecular signature in not women without AD who are younger. And if we follow the same women over time, we're actually seeing loss of these protective molecules as they age. And especially this loss is more pronounced in aging women who developed Alzheimer's. So what does this tell us? This is telling us that yes, your immune system is changing as you age, and in some ways may be accounting for a loss of immunoprotective molecules that would prevent disease. And this is just something that we would not have picked up if we didn't separate the profiles, the molecular profiles that we're detecting between the sexes. And we're learning things that are relevant for both women and men.
Yes, of course. It affects both, obviously. Well, thank you, Sonia, for the incredible work that you're doing to investigate sex-based differences in neurodegeneration. You know how much we're enthusiastic, interested in, and pleased that you're so involved. I'd now like to introduce an incredible physician who I've known for a number of years who takes this research and implements it on the bedside. Dr. Lisa Christopher Stein, who's a professor of medicine and neurology at Johns Hopkins University School of Medicine. Lisa, Tell us a little bit about one or more rheumatologic autoimmune diseases in which you noticed that your own perception of how a woman presents with the disease has changed, because it has obviously over the past decade.
So much so. First, I'd like to thank you so much for being part of today. And it's just such an energy I feel hearing my colleagues speak about this such important topic. And thanks for bringing attention to it, Carolee. I think everything has changed, right? And hearing my colleagues just echo what I'm learning in real time, how could we not know? I love the example of blue jeans, right? We buy different jeans, we don't look alike on the outside. How could we ever think our immune systems are perfectly symmetrical between men and women? So for me, there are two different diseases, and I'll just preface this by the fact that my title has a professor of neurology and medicine. I have an adjunct appointment in neurology because of the work that I do in muscle disease. So I focus my time as a rheumatologist on autoimmune muscle diseases, but I also see diseases that affect the joints in an inflammatory fashion. So I'll juxtapose two and just tell you sort of the story over time that I've seen. One is ankylosing spondylitis. So this is a chronic inflammatory spine disease. It's mostly of the spine joints, especially the sacroiliac joint, which is at the base of the spine. And people with ankylosing spondylitis also can have inflammation of other joints. And so there's been this sort of metamorphosis in my training. And so I've been in the field a little over 20 years, and we have just really, I think more recently, really appreciated these incredible differences. And I always say that you cannot diagnose what you don't know. Or if you're looking over here and the answer is over here, you won't see it. And I think that happens so often. So with ankylosing spondylitis, it was, to me, taught initially that this is a more prevalent disease in men. And so if you're only looking for it mostly in men, of course, you're going to miss the women with it because you're not even primed or posed to see that. Now we know that it's almost certainly underdiagnosed in women. And how do we know that? Well, studies over time that look at these incredible differences, and we see it for sure in autoimmunity in the opposite direction, where diseases like lupus are anywhere in different estimates of 8 to 10 to 1 women to men. Ankylosing spondylitis, kind of at the beginning of my training, was said to be maybe around a 10 or an 8 to 1 ratio between men actually having the disease more often. It turns out it's almost equal. So over time, not only do women have this, they have this almost certainly probably as much as men. Then we were taught, well, maybe the disease presents differently in women. And that's true of the second story I'll tell you a bit about. So this has been a metamorphosis as well. At first they said, well, no, it doesn't present that way. That's why we're missing it. It's actually, instead of the axial spine, which is your spine, it's more in the peripheral joints. And so while women do have a little bit of a different presentation of the disease for sure, it turns out that they indeed do have spinal disease, but they get diagnosed up to 2 years or more later than their male counterparts. And it doesn't take rocket science to know that when that happens, we've already lost 2 years of precious time to institute anti-inflammatory therapies, biologic therapies that could have been useful 2 years prior. And what happens when you don't prevent that inflammatory response? Well, you develop ankylosis. In other words, a fusion of the joints of your spine and other joints. So I think that it's not it's something that can be learned and taught, and this starts at medical school. And what is the problem? Well, part of the problem is that for years, research really focused here. It was mostly on men. That is starting to change. So recent studies have included more women, thankfully, but we're not even there yet. There is not enough data to really even reach firm conclusions about these differences between men and women in this disease. And that is imperative. It is life and limb saving, right? So for sure. The second disease that is, again, this is really recent, and that is in my own field specifically of research and clinical work, and it's something called inclusion body myositis. Again, these are rare diseases that don't come to the tip of the tongue, but in fact, that's the most common inflammatory muscle disease over the age of 50. And until very recently, I teach it. I've always been sort of taught it's about 2 to 3 men to women. I think it's going to have the same story that we saw with ankylosing spondylitis. In fact, it may not be more common. It is just missed. It is missed, and it takes a longer time for diagnosis for sure. So inclusion body myositis is classically taught to present as a relatively painless weakness. This happens as people try to rise up from a chair, reach over their head. And the classic symptoms that we teach physicians to look for are problems, for example, in finger grip. This is something that unusually affects what's called the distal muscles. Most of the inflammatory muscle diseases we see affect the proximal muscles, so the shoulder or hip girdle. Inclusion body myositis classically affects the hands, and it's a problem with grip and making a fist curl, so a finger curl. The other thing it does is affect the quadriceps. And so it would be difficult, for example, to do knee extension. So the classic features of the disease are decreased knee extension and grip strength and inability to flex the fingers, right? The finger flexors. Over the course of seeing women with this disease, it dawned on me that a lot of the times women present with very subtle disease. They don't present the same way as their male counterparts. In fact, they may not develop finger flexor weakness or develop it much later. They may never really have the same amount of quadricep weakness, but different muscles are weak. And if you look under the microscope, so this disease gets its name from the inclusions or little holes or what's called vacuoles that we see under a microscope, in which that's a pathologic diagnosis. It looks similar, at least under the microscope, but we are missing it clinically in the way it presents in women for sure. So we also then, colleagues of mine in my research group, we looked at our own cohort and over 300 patients with inclusion body myositis. And we compared them to over 500 patients with a different type of inflammatory muscle disease. It's also called myositis, but it's not this one. And I don't think you'll be shocked to know that women are misdiagnosed more often. Is this a similar story? Diagnosed much later than their male counterparts. And I already told you that they present very differently with these cardinal features. So once again, if we're teaching one thing, but seeing another, it is our duty to uncover these very important clinical features and then maybe importantly, transfer them back and translate them to the bench to say, look, at the research bench, if we're seeing the presentation different in the clinic, it must mean that something is different at the research bench itself, which begs to ask the question, are treatments, should they be tailored differently for women, for example? The other thing I have seen is that there is more of an overlap with more typical autoimmune diseases in women who have inclusion body myositis versus their male counterparts that don't in general seem to display those. And if you're not thinking about that and not looking for it, you will miss it. So I can't say enough about the education that I think I have in real time. I experience where my patients are the teacher, right? It's the Latin word for doctor is to teach. I think the biggest teacher is the patient, and we have to be honest with ourselves that when diseases don't present themselves the way we're taught they should, we have to ask ourselves, why is that? And it's the patient that's going to teach us that every time.
Well, thank you, for all of that, Lisa. And of course, everyone was sitting here doing knee extensions and finger curls. Tell me about your observations in terms of diagnosing, and that's what you've touched on in the comments that you've just made. But we know that sometimes it can take up to 8 to 10 years before, and Erica touched on this as well, before an actual diagnosis is made for all the reasons that we all know. And Megan's book portrays this quite vividly. What obviously, as a woman, and you're much more sensitive and tuned to this, and clearly have had a different kind of experience, but what are you finding in terms of just across the board of how women should be looking for the kind of diagnosis that they need? What kind of advice can you give them?
Yeah, so I thought the same. And when reading Megan's book, I often thought to myself, am I the kind of doctor that she would have been happy to see? And I hope that I have been. I'll preface my answer to your question, but the answer that for me, I tell patients that, and I frequently have to tell patients with autoimmune diseases, they can be very murky. And just because the person doesn't come to you and have the textbook, classic case of autoimmune disease, I think we have to be careful not to blame the patient. And I will tell them two things. First, I think one of the most courageous things that I'll do as a physician is to say that I don't know. I teach medical students, and I once had an experience where there was a pulse that was hard to find. I said, oh, I don't feel it. And there was an audible gasp. And I thought to myself, wow, are we teaching students that they have to know everything? So I think the first thing is, again, it starts with education. That goes all the way up to emeritus professors. I think that we should be cognizant of the fact that the discomfort of not knowing is such an important part of discovery and partnering with your patient. I was relieved to hear that Megan wrote about this idea that, and others have said, I just wish someone would say, I don't know, but I believe you. I believe there's something wrong. And I'll do my best to help. I may not always be able to do that. And I'll be honest when I cannot. So I think that's first that conversation from our point of view. And then it's the patient's point of view. So years ago, when we first launched and opened our myositis center, so in 2007, I was very fortunate to be able to tell this story of 3 female patients of mine on Good Morning America. And the 3 women that they profiled told their stories of a delay in diagnosis. So what is myositis? Myositis is an autoimmune condition that affects the muscles. And just like rheumatoid arthritis targets the joints, for reasons we don't know, the immune system puts an abnormal tag, tells the immune system of this woman's body to say, go and attack there, and it attacks her own muscle. And the features are often, what I told you before, difficulty rising out of a chair, hard to reach over your head. There's fatigue with autoimmune disease for reasons I think that are very compelling and interesting and not well understood. So they present or they tell their doctor, boy, I'm feeling tired, I'm a bit weak. 3 different women who had different forms of this disease were told 3 things. One was told that she was overweight. She should lose weight and it'll all go away. The second was told she was crazy, right? So this is in your head, figure that out. The third, and one of the most amazing stories I recall, I met this young woman, 20 years old, with a 1-year-old child. She was told, you're depressed, you're anxious, you're a new mom. It's that. Nobody had examined her. Nobody had ever asked her when she said that she was weak, did this really mean fatigue or was something else? By the time I met her, she had a black eye because she had fallen over in a parking lot and sustained an injury because she couldn't even sustain her own weight. She wasn't anxious or depressed. She was sick. And people don't hear that. So for me, this idea of women who I think are now having more of a voice, I think forums like this and education and women being involved in the care of other women, I'm hopeful that both male and female physicians, for sure, will be sensitive to the fact that blaming the patient, or just because we don't have the answer, or not taking the proper time to take a proper history and examine a patient, is not acceptable. And we are so much more likely to do this with women than we are with male patients. I think when you know it, you have to fix it, teach it, and change it.
Well, thank you for that. Lisa, while I have you, a question just came in that I'd like to ask you because it's relevant to what you just said. Do we know what triggers these muscular autoimmune diseases? And has there been any correlation to receiving either epidurals or vaccinations that trigger polymyositis? And I think, Erica, you might want to chime in on that as well.
I'll start and then I'm happy to hear Erica's thoughts. I mean, so the first answer for sure, we studied flare of underlying autoimmune disease, and we did not see in myositis, thankfully, a huge signal of flare with post-vaccination with regard to COVID. It's a little difficult because some of the symptoms of flare, you can imagine, are muscle pain and a little bit of fatigue. And so it was a little difficult to tease out, but very few patients required immunosuppressive therapy after a vaccine if they already had myositis. I did see evidence of autoimmune muscle disease. And again, we have a report in progress about this. So it was rare, but yes, it can happen. Having said that, exceedingly rare, and I felt like the risk-benefit profile was tipped strongly towards vaccination for sure. I think there was a second one you had asked me. Other than vaccines, there was another environmental trigger. Is that correct?
Epidurals.
I don't know any data with regard to epidural specifically. I can't comment on that. I mean, obviously, any invasive procedure in the body, theoretically surgery, any kind of thing can set the immune system off in theory. I'll leave with one other instigator. And again, this is an example in my experience where it was a disease that was a different story than I knew. So, and that is with regard to statin myopathy. The vast majority of people can take statins safely. So statins are that cholesterol lowering drug. atorvastatin, rosuvastatin. It's the most commonly prescribed drug class for cholesterol reduction. And we know that statins certainly irritate muscles in a certain number of patients. Patients tell us this. Again, the question is that overrepresented? It's clear it happens. And most of that seems to be a direct injury from the statin. And so that was the paradigm we had. So the statin injures your muscle, you stop the statin, you get better, maybe you try another statin, maybe you can't tolerate it, and you figure out your pathway with your doctor. We did see a community of people who came in, these were both men and women, and they said, something is wrong with my muscle. I think it's the statin. And in fact, they did not have a murky diagnosis in the sense that if you looked at their blood, they had high levels of muscle enzymes in their blood, much more than we should normally see there. So there was definitely muscle injury. If you biopsied their muscles and you looked under the microscope, you didn't see any inflammatory cells, which are called lymphocytes, right? No B cells there, no T cells there like we usually see. You did see the muscle cells were dying. There was something wrong. They were regenerating and degenerating. And we said, well, I don't think it's the statin, because the patient said, so when did you take your statin? They said, oh, I started it about 3 years ago. We said, well, it can't be the statin. Then they said, we stopped it. And I said, did it get better? And they said, no, it's getting worse. We said, it can't be the statin. It turns out, through a series of very eloquent experiments and really taking the patient's word in the clinic, going to the bench and then going back to the clinic, we were able to identify a very specific autoantibody, an antibody against a self-protein that is present in patients who take statins. Again, most of the statin myopathy is a toxic, direct myotoxin. You stop it, you get better. But in this fraction of patients, it was the statin. And we found out that it broke all the rules. It happened years after starting the statin. It happened and got worse when the statin stopped. So just because physicians didn't have a paradigm for that disease state, we then told the patients they were wrong, and they were 100% right. So that's my answer. And I think there are a lot of environmental triggers, including I really thought hard about listening to Megan in her book, about viral triggers. We've seen this in multiple sclerosis recently. We've seen this work in lupus. And I think it's very clear that we have a lot of work to do. Certainly my colleagues on the screen are experts in that work. And I think working together we'll have better answers for exactly what does this in the environment. Thanks.
Thank you. Erica?
Yeah, there are a lot of interesting triggers of autoimmune disease, and it varies, of course, by disease, environmental and also hormonal. Some environmental triggers, like Lisa just said, are viral. And so sometimes what that means is that a protein in the virus, a molecule in the virus, resembles a human molecule. And so in the course of that viral infection, you'll mount an immune response against that, and it'll cross-react to your human protein, and it'll continue that attack. Also, a viral infection or a bacterial or fungal infection could just upregulate your immune response. While your immune response is primed and active, and you're launching lots of different immune cells and pro-inflammatory cytokines to get rid of that infection, you might persist in that inflammatory state. And if you just have more armies launched, they're going to be more likely to have misfired shots. There are other environmental triggers too, that affect all kinds of things in transcriptional control. So there are chemicals in plastics that can affect hormonal responses to different things. And some of the dramatic rise in autoimmune disease in the last couple of decades could very well be linked either to emergence of new pathogens or exposure to new pathogens or exposure to some environmental molecule. And it very well could be plastics or some other component of our modern life that causes an altered transcriptional response in your cells. That means your cells turn on and off different things and affect how our immune system functions. And also, some of the times where we don't know that trigger could be if it was launched by some kind of infection. There's lots of different viruses and bacteria that we are infected with that we carry around as passengers, and they don't really cause a notable disease. In addition to your microbiome, you constantly carry a virome. You have lots of viruses all the time. And if that virus has just come and your immune system has controlled it and then it's gone, there's no disease of note, and no one may have discovered that virus or discovered the effects of that virus. And then if it triggered a cross-reactive immune response, and you might not see that autoimmune disease until quite some time later, when the evidence of that virus is gone. And if we don't know what the virus was, we can't measure whether you have an immune response against it. So it's long enough later that there's no smoking gun to find it. And hormonal control of what genes turn on and off and how your cells function should not be underestimated. I mean, all you have to do is think about the changes in puberty to know the dramatic effects of more or less estrogen or androgen. You know, as you watch your little boy turn into a man or your little girl turn into a woman, or if you watch a woman get pregnant and all of a sudden she grows another human being, starts to produce milk, you know, the remarkable changes that happen in pregnancy, and how, you know, even in pregnancy with those changes in hormonal levels, many autoimmune diseases are suppressed and the symptoms go away until sometime after she gives birth. So the effects of hormones are incredibly powerful on everything in our bodies, including what our immune responses are. And so women go through a couple additional remarkable hormonal changes. So in addition to puberty, where everybody goes through, there are also changes in menopause, where levels of certain hormones change over, you know, a year or two. And as we get pregnant and give birth, you know, 1, 2, 3 times in our life, those are dramatic changes of how hormones go up, hormones go down. And a lot of the exhaustion and fatigue that we see in autoimmune disease may in fact closely resemble the fatigue that we see in the first trimester of pregnancy, or the fatigue that you see when you are sick. You know, when you have the flu, you're exhausted. When you're getting better from the flu, you're exhausted, you're tired. That's a lot of that is that the immune system has a tremendous caloric cost to it. Your body is making lots of new cells and making and destroying thousands of immune sentries. That's a lot of material made and destroyed and launched in a sacrificial attack to protect yourself. Of course you're tired. If you have an autoimmune, you expect that when you have the flu, but if you have an autoimmune disease as well, that may well be what's happening. That's why there are these generalized symptoms that are hard to assign to different things. So
sorry, Harry.
No, go ahead.
No, please finish. I didn't mean to interrupt.
Yeah, so there's lots of different triggers, and sometimes they are varied and complex, and it's hard to tease them apart. But the wonderful opportunity for science here is that if you have a clear variable and you see a clear result, you learn something. And in this cell, in response to this response, something turns on, and that's linked to disease, then you can figure out what it is. And so that's why we're particularly excited about some of the work we're doing here. So our professor Pandurangan Vijayanand has looked at 1,500 different genes on your body chromosomes that are on or off, whether you're a male cell or a female cell. And our professor Greg Samoa has looked at, you know, why do males suffer more from asthma? If you can find a difference, you can find an answer. And if you find an answer, you have a route for treatment.
So do we need more, this is the perfect segue, to a question that just came in, do we need more preclinical studies which look at sex as a biological variable? And if so, how can we incentivize this work?
We absolutely do. So in science, all you can ask for is a clear variable and a clear result. If you see the presence and absence of some factor links to the presence and absence of some disease, you have some place to go. You have a diagnostic, you have a biochemical pathway that you can develop a drug against, you have some actionable information. If you don't do the research, you don't have the information. If you don't shine a light in a cave, you don't see what's there. And you only see what is in the beam of that flashlight. And if the real action is in the roof of the cave and you're busy looking at the floor, you're not going to find what you're looking for. What I'm excited about is that the more we study this area and the more we uncover, the broader that flashlight beam is. And if philanthropic funding can help us do the proof of concept studies to attract federal funding, or if federal funding organizations see the opportunity here for human health and people of both sexes, that beam gets broader and broader. And there's more of an opportunity to do the work we need to have the information to put things in doctors' hands.
Yeah, for sure. There's no question. And I think one of the things that WHAM is quite focused on is how to create change and how to create impact and how to improve the amount of research dollars. And we were thrilled to see in a recent omnibus bill that there was $10 million allocated to the Office for Research on Women's Health to launch an autoimmune office. And I think that'll be spectacular. So it's a good start. Again, it's not enough, but it's a start. Many of you know that we're launching a very robust social media campaign, 3 Not 30, during this coming year to focus on what needs to be changed in the next 3 years. None of us have another 30 that we want to wait and see these changes to take place. And I'd like to turn to the panelists. And Sonia, I'd like to start with you to ask you, what is it that you'd like to see change in the next 3 years?
So I'd just like to quickly say that, I feel like we're perfectly poised to make groundbreaking discoveries in autoimmunity and other sex-biased diseases. The technologies are there. What I'd like to see is that we execute. And in order to execute, we need to educate, advocate, be involved just as much as in our healthcare as in our biomed research. So I'd like to see more research on sex-based diseases, more research that takes into account the differences between the sexes.
Which of course is what one of WHAM's major missions is, to see how we can accelerate the role of research, which we know affects the economy. So we're doing the best we can. Not enough, not quickly enough, but we're on the same path. Lisa?
I would echo that for sure. As I think about that question, I think part of it also is who sits at the table. So a huge mission for me, having to climb the academic ladder, is to make sure that we're appropriately represented at the table. And that means as deans of medical schools, as full professors. If you look at the data, for years, I thought it was a pipeline problem. It's not a pipeline problem. We now represent over 50% of medical students are women. And it stalls at often the assistant professor level. So many of our academic junior faculty are women, but they don't always get to the point where they can, in fact, influence policy. It's policy at the local and the national level. So I would love to see more emphasis, and I think that there is a big push for this for sure, but we need to push harder for women to be at the table where their voice is heard and advocate for exactly what Dr. Sharma and others on this panel, know need to be done. She's correct. The technology is there. Well, obviously, always funding is necessary, but then you need a voice at the table in advocacy, and that comes when we represent that voice at the top where it needs to be represented.
Yeah, for sure. Erica, I'm sure you have a few opinions on this.
We can make a lot of progress in 3 years, and there is absolutely no need to wait for 30 years. So what we have in place are a lot of the foundational studies where we've built the tools that can measure all of the different factors that make one immune response different from another. I mean, we've seen in COVID how some people are intubated and other people don't know they're infected. There's a reason for that. It has to do with their prior exposure history, their metabolomics, their genetics. And with these larger tools, we can quantify that information. And now we've started to put the foundational studies in place, are already there, where we can start to mine the information. So being aware of the problem, doing the study to create the body information, and now we know the list of genes, we can mine them. And the other thing we're going to do in the next 3 years is build a body of faculty that are focused on this area. And that's going to have a force multiplying effect, where the more people are thinking about this, the more different tools we apply, the more we can accelerate our progress.
Yeah, for sure. And there's a question, Erica, that I think is relative to this, which is exciting, which says, you eloquently explained that if we don't shine the light properly, we'll miss the undiscovered processes that are all affecting diseases. How can researchers at other institutions collaborate with La Jolla to move forward in understanding sex differences?
Well, we're building broad collaborations and disease focus centers to work on this. And so we very much welcome collaborators from other parts of the world that have different tools or different clinical samples. A lot of the pioneering studies that Dr. Sharma has done come from clinical samples. Some were collected in Europe, some collected in Seattle, some collected in San Diego. So there's lots of opportunities to have people that have either clinical samples from a certain site can be analyzed with the tools here, or to come here and join us and do these studies, or send things back and forth. Often in my work, I'll engineer something at La Jolla Institute, and then it goes to be tested preclinically at another site. So there's lots of opportunities for collaboration.
So I think anyone who's interested should reach out, and I'm sure that there's someone at LJI who will point you in the right direction. Lisa, I'd like to just ask one more question that's been asked a few times, which is, is there any way to reduce inflammation?
Isn't that the $1 million question?
Yeah,
I mean, I think there are a lot of ways. And so interestingly, again, this is not something that you will be shocked to hear. One of them is to exercise regularly. Why? Exercise itself is actually natural and very natural anti-inflammatory. I always say I think that exercise is probably one of the best anti-aging mechanisms that we have. The other thing is, and it's easier to say and hard to do, is to try to maintain a normal weight. And why is that? Well, every fat cell called an adipocyte is its own little inflammatory factory. So even I think people feel sort of overwhelmed and think they need to maybe lose a lot of weight. I always recommend that even modest amounts of weight loss really do decrease your inflammatory burden. Patients feel it, obviously feeling better for sure, but on really a cellular level, there's a strong likelihood that adipose tissue or fat tissue is its own little inflammatory factory in our bodies. So those things. As far as what can you sort of do in lifestyle, people ask about diet all the time. I'm going to be very careful. I've recommended certain, possible elimination diets. I think this is murky science, and it's not because it's not reputable or important. I always say I had 4 hours of nutrition and 4 hours of education and 4 years of medical school. I love asking the doctor the nutrition questions. We're just always not the best people to ask that, whereas we're not formally trained. And part of the problem of diet science is that you're not a lab animal, and it can't put you in a little box and make it sterile and make sure you eat what we tell you to eat. It's easier to do those studies on a controlled environment that humans just don't really always do as well with. I think Erica mentioned the microbiome, for which I have extraordinary interest. I think there's probably much more to know about diet and the way it affects your microbiome and your inflammatory response. I don't know that we're there yet. Many people do their own work in that way. The Whole30 is one, particular. I'm not sure that I necessarily advocate for all of it and what they believe are inflammatory, but I think it's a nice idea to say, look, let's eliminate lots of things and then gradually reintroduce them and see if they bother you on an individual level. And then finally, supplements. I'm careful here, but I think the one supplement that rings true that seems to be pretty innocuous, but you have to take it in the proper way, and that's turmeric or curcumin. It's a very nice natural inflammatory. It is relatively harmless. Many other herbal supplements do have interactions with the medications that we prescribe in allopathic medicine, so I'm careful to recommend them. But taking curcumin as a supplement, and it needs to be, we can't really get enough dietary curcumin in food. It also is absorbed whether with black pepper and other additives in a capsule. So those kind of natural things, but it's not rocket science. Again, normal weight, regular exercise, eat whole foods as they came to the planet, do perimeter shopping, and don't shop in the middle of your grocery store and eat processed food. And really that is and obviously an adequate rest. I do think that many patients have sleep disturbances that I see. Again, that's not well understood or studied, but certainly adequate sleep, again, sometimes harder to do than, it's easy to say and hard to do for some folks, but those simple measures really do decrease your inflammatory burden on a daily basis.
Well, I appreciate that, and all of the comments from all of our wonderful panelists. And we are sorry that Megan had a problem with her son, and we'll have to just redo this panel with her, and that would be fantastic. So I guess the question becomes, why is our campaign 3 Not 30 our call to action? And it's because we believe that collectively we have the economic power to create change. And we recognize that women drive the economy. In the US, we make up more than 50% of the workforce, 52% of the population, own 60% of the wealth in the country, and are responsible for 85% of consumer spending. We also make 80% of the healthcare decisions, and we're the healthcare officers, chief officers of our families. Let's create the changes together that we set forth today so that women and society flourish in 3 years, not 30. And for more information on WHAM, please visit whamnow.org. You can follow us on social media. So thank you all so much for joining us. Thank you to my panelists and for the great work that you do.